Good morning.
How are you?
Great and yourself. Like, turn your volume down a little more.
It's me. It's me.
Yeah.
It's me. Is that better? No?
No. Mm-mm. You still it's
You said it's a buzz somewhere. I don't know where the buzz.
and but it's like it's like you're coming through like really loud and clear.
But it's a buzz.
Yeah. But the buzz is like low level, but like you're really loud.
Oh, I'm loud. I'm the loud one
Hmm.
in the room. Okay. Is that better? Am I sitting too close to the mic? I don't know.
All right. Don't let's just press on towards the mark.
Like, is it just me? I don't know. See, one week we have everything nice and great, and the next week it falls apart. I don't know. Okay. Well, as long as we can hear, let me see. Can I hear?
Definitely. I like that scarf.
Oh, thank you. Oh, I do hear me. Okay. Well, I can sit back. I don't know. Maybe I'm too close. Maybe it's the gain. Hold on. Let me see. Do I have the gain on over here? Is it better?
It's all
No.
right.
Okay. Let it go. Let it go. Move on. Move on. All right. All right. Well, hello. Hello. Welcome, everybody. I see folks in the room. Welcome, Renee, Shay, and CK. What's happening? Welcome. Welcome to our Saturday morning tea. Yes. where
Definitely.
where we discuss health information, news, education, certification tips, entrepreneurship, some of the foolishness that we be seeing out here in these healthcare streets, and all of the things. I am Clarice Warner. I am the girl with the pearls, the founder and education director of the Professional Reimbursement Network, LLC, where coding education is key. And before I get started, do you know what it takes to be a certified marketable medical coder? Do you? Do you really? Do you think you do? Well, before I introduce my co host, let me share with you some information on a free, yes, free 99 email course on the 5 steps to become a certified marketable medical coder. Are you interested in medical coding, but not sure where to start? And scared of wasting time and resources? Let me help you with the right steps to become a certified marketable medical coder. Learn more at bit.ly/5stepscoder. All right, all right. So if you are in Clubhouse and you are interested in getting more information on those steps to become a certified marketable medical coder, you can check out the link. Also, if you are on YouTube, Facebook, and LinkedIn, you can check out the video description for the link. And I promise you, it's in there. Just keep scrolling. It's down there. It's in there. So joining me today is my illustrious co-host and friend, Mr. Jesse, the registered, well, actually, he's more like family, the registered trademark, the coding nurse. Sir, introduce yourself and tell the folks all about you.
Good morning, all. Good morning. My name is Jesse. I live in Philadelphia. I've been a nurse for quite a long time. During the pandemic, I transitioned to become an entrepreneur and created a company called the Coding Nurse, where I help nurses and people with other clinical backgrounds transition into the wonderful world of HIM.
Cool, cool. All right, all right. And how's all that going?
It's coming along nicely. And before we start, I really would like to say something to the people in Clubhouse. This is an interactive community. Like, don't just sit on the sidelines. Feel free to come on stage. It's interactive. Like, you don't, yes, you do come here to, to hear Clarice and I, but we also come to hear from you guys. So don't be shy. Come on up.
You done stole the line. Look, that's gonna be your new part from now on. You done grabbed the whole piece of the section. Yes, yes. So as most of you know, we started in the rooms of Clubhouse and would have a great conversation and dialogue. And I know that we're recording, and so I don't know, sometimes that makes people feel a little gun shy, but it's your opinion, and your opinion matters, and we're looking to share. And I'm always about trying to figure out and see, well, what does the masses think, and where should we go from there, and then being strategic on what the next course of action should be. So yeah, don't be shy. Come on in, come and talk to us, because we've put together this platform where we can engage on Clubhouse as well as share the information with others. And so yeah, they get down in the comments. So we want the folks
Yes.
over in Clubhouse to be able to engage and share in the information as well. So don't be shy. Don't be shy. Come on in. Well, first, let me just say it's March, and it's Women's History Month. So happy Women's History Month.
Okay.
We always about making some history. I saw, oh God, I'm gonna have to bring that next week. I may even order the shirt. I saw a shirt that said something about women and history, and I was like, it was so spot on. And then next week on the 8th is International Women's Day. So there's a day within the
Okay.
whole month. So just be mindful of that. I did wear my Invest in Black Women's shirt. We have a local entrepreneur here who is all about financial literacy for um, youth and adults and businesses and all of the things. And he has um, um, shirts that say "Invest in Black Women." So I was sporting. I think I got 2 or 3 of those shirts. So I be wearing them. I had to be mindful, especially one of them. I got a yellow and black. That's kind of Steelers colors. We don't play in those streets. So so I have to put on something to mask those black and yellow colors. The bingo in me won't let me do it. Okay. All right. So today, um, we're gonna talk about a couple little things that piqued my curiosity and dropped into my my world. So if you are just joining us today, we're going to talk about, well, one, an update on the RN license scandal and Nightingale and all of those things. So there's slowly but surely little bits and pieces of information that's trickling out. So I wanted to provide like an update of something I found. Plus, another scandal. We talked about this when we talked about the Nightingale, but there's still some folks out here living their best lives uh, illegally. I'll say it that way. Um, and then this other piece about the physicians. Y'all, let me just say, the AMA must be full of money. That's all I got. So the AMA and the physicians are out here fighting against prior authorizations. And I did not realize how big the fight was. I saw one little article and it morphed into all kinds of things. And so I spent a lot of time this week getting up to speed on what is happening with the AMA and their prior authorization. So let me start there, because again, there is money out here in these streets that I did not know about. So
But we should have been
go ahead.
we should have been aware, or that was our little introduction. It was going to be something, because when the AMA put out that little hit piece on nurse practitioners, we had said then it was shots fired. So now we see they are pressing the gas.
They got an AK rifle and they just going across the board. Everybody getting a piece. Everybody gets some. It's some for everybody. And I was like, I, I said, wow. It's wow. So one of the things I wanted to kind of set the stage with is, and this I did not know. I saw an article from like the AMA kind of has their own like little news feed. And so an article from Kevin O'Reilly. This was actually an article last year, but it sets the stage for what's happening now and moving forward. So there was an act, the Improving Seniors Timely Access to Care Act of 2022, that it had bipartisan support. It hit the different committees, but the main committee was the Ways and Means Committee, and its chair from Massachusetts, and then who's a Democrat, and then there's also a ranking member, which is a Republican from Texas, Kevin Brady. So they all got their members together, both Democrats, Republicans. They're like, yes, they're all about this bill. And so, if you know anything about politics and how these bills work, yeah, they'll have an overarching theme, but 9 times out of 10, you have like a gazillion little bitty bills folded into them. And so sometimes, even though everybody may agree on what the main overarching bill is, there will be something in those little bills that they're like, we're not fooling with that. And so it sometimes gets struck down, and then they have to come back and recreate, and so on and so forth. So that's how kind of the game is played, if you don't know. But in this game, they had some additional information about prior authorization. And the AMA has this whole recovery plan for Americans' physicians. And it starts with this. When I first read it, I was like, they playing on the heartstring. They doing all kinds of things. So it says like, you took care of the nation. So it's time for the nation to take care of you. It's time to rebuild, and the AMA is ready. So they're all about. I didn't turn my focus on. Hold on, because Lord, if this phone ring, I promise you we're gonna have a problem. They're all about various components and aspects of what's happening. So let me share it with you, this little bitty video that kind of talks to how they're setting the stage. Wait a minute, let me put this. Present. Okay. All right, let me play this video. Hopefully you guys can hear it. Hopefully we won't have any problems.
When we needed you most, you were there. When the world seemed to fall apart, you held it together. After 2 years of taking care of this nation, it's time this nation renews its commitment to you. We need a recovery plan for America's physicians. The AMA stood by America's physicians and patients during the pandemic, securing billions in emergency funding, preventing Medicare cuts, fighting for telehealth coverage and payment, combating misinformation, and backing
I'm swirling.
Medicare payment, and supporting telehealth, fighting scope creep, and reducing physician burnout. To rebuild, and the AMA is ready.
Didn't you feel some kind of way? Didn't you feel did you feel some kind of way when you saw that? I see your face. How did that make you feel when you saw that?
Honestly, amused.
I was like, boy, they got a lot of money. That's all I had. Good morning, Crafty Coder.
because it didn't work. I mean, it didn't work for the nurses. So we're going to see, because this comes down to a whole lot of things. This, because there's always a sub story, and the underlying what I want to see is, now we have, let's just call it what it is. Now we have white men complaining. Let's see what happens.
That's the truth. It's a whole different spin. It's a whole different spin. But well, I'll give a couple thoughts in a minute, because I need that same energy to turn to some other areas. But I think there's
Mhm.
some room for all kinds of improvement. So there's actually legislation. So the House Ways and Means Committee passed a new modified prior authorization reform bill. It's HR 8487, the Improving Seniors Timely Access to Care Act of 2022. And in this, they are targeting Medicare Advantage plans to implement electronic prior authorization programs that adhere to the newly developed federal standards, as well as establish real-time decision-making processes for items and services that are identified as, quote, routinely approved. It mandates that Medicare Advantage plans issue accelerated prior authorization decisions for all other services in Medicare Part C, and then enhance transparency by requiring Medicare Advantage plans report to the CMS on the extent of their use of prior authorization and the rate of approvals and denials. And so we saw, and I think we talked about this too a couple weeks ago, related to what they are planning for Medicare Advantage, and making sure that they are in line with your traditional fee-for-service Medicare. So they're setting the whole stage. So then I ran into this whole piece of this is from an article by Sarah Berg, who talked about, well, what doctors wished patients knew about prior authorizations. And it's like, medicine, it's a triad. You have your patient, you have your provider, and then you have insurance. And so there's always fighting in that triad. One way or another, somebody is pointing fingers and at one or the other, or both, or how you need to do it. And this is just, I think, another attempt at kind of pointing the fingers at some folks. So physicians wish that patients knew that insurance companies want to spend less. So it's pretty much the stand that they don't want to spend the money that they're getting from the premiums from folks. They want to hold on to it. And one way for them to do that is to deny care, or um and they feel like it's not only, oh, let me just add, so this fight is not only physicians, even though I guess they have the most, but then you have pharmacy is on board. And so they're tying the actual medical services that physicians or providers provide, and then the medications. And so they have some allies in this fight. So they got that front line, and then they got a couple of lines behind. So it's gonna be real interesting to see. Another thing that physicians wish patients knew, that it complicates. So all this prior authorization stuff complicates their medical decision making. And they have to try to figure out, well, what can we do once they diagnose and treat the patient? Then they have to take into account, well, that other arm, will you have this type of insurance, or you have this going on? So what can we do? What can't we do? This may be our plan, but the insurance companies may ultimately say no. So we need to come up with a plan B. So it complicates things. Also, prior authorization is a guessing game. You never really know what the insurer wants to determine to give that authorization. Sometimes they want to, I see somebody coming in. Sometimes they want to have a specific piece of paper. The providers may be sending everything they got, and it's still a no. And so they really don't know what the insurer is looking for in that. And so that takes up a lot of time, takes up a lot of resources on the provider's side. They said fighting rejections is also time consuming. These barriers are harmful to patients. They said they also know that even with the fighting, sometimes patients get frustrated, they walk away, they don't get the medication, they won't get the treatment. It risks bad outcomes, hospitalizations for patients. They're stuck with the bill. It goes on and on and on. Prior authorization is unpredictable. Services once covered may change. So today they may say, "Oh yeah, we'll cover that and pay for that." Tomorrow it may be they may not, and nothing has changed as far as the patient's diagnosis, the assessment of the patient, so on and so forth. And then physicians are just frustrated with this whole process. They put their foot in the sand to say, we are not the ones to set up this prior authorization system, but we have to play this game, and they're frustrated with it. And then they want to let you know that they are working to put forth efforts in order to fix prior authorization. Okay, I'll pause right there before I get to the big dogs that they want to do. Hey, Renee, you're coming to the stage. Welcome.
Good morning. How are you?
Good. How you doing?
I am good. Thank you for asking. I just wanted to add, hey, everybody. Hey, Jesse. Hey, everybody.
Hey, Renee.
So I wanted to add to that about the prior authorizations because I was working for an insurance company. And so what happened is, you're right, prior authorizations are just, they're a mess all around. And so when you were saying that the insurance companies, they will go back and change and revise things, that is absolutely true. Things change every day. So I know for the state of Texas, they have what's called a new bill, because the providers were saying, like you were saying, the patients were having adverse reactions and passing away because they weren't getting procedures because of the prior authorization. So what the state of Texas has done is they have something called the House Bill 3459, the Gold Card Act. And what that allows is a few providers to not have to go through the pre-authorization or the prior authorization process. And so if they have a certain criteria that they meet for, I think it's 6 months, then the insurance will reevaluate them to make sure they can keep that gold card status. And so they're not going through that process, and it's actually being changed over because providers weren't clear about the difference between a prior authorization and a pre-authorization. And so that was confusing. So they're changing the lingo to reflect RCR. So when insurance companies are reviewing for these pre-authorizations or prior authorizations, it's going to be a difference in for these said providers if you meet a standard. And I believe that the insurance company is responsible in the state of Texas so far. I don't know about any other states, but in Texas so far, the insurance company is going to be responsible for working with the providers to say that, yes, you meet criteria based on your previous history of billing to us. You meet the criteria that we can offer you this gold card service. So it's very interesting, information. And when you're saying that the insurance companies do change, they use a medical policy to determine if the people meet criteria for different procedures. So for instance, like a bariatric procedure, they have to have the psych evaluation done. There has to be a show of weight loss that the person tried on their own. There's like a list of things that have to happen before they can even be eligible to even read, hey, did you all meet the medical necessity for this procedure? So that's how they go about, the insurance companies go about making sure that they feel that that person, that doctor tried at least 3 avenues or maybe 2, just depending on what the policy says. But did you try to get them to have like less conservative measures before you go into this invasive procedure that you want them to have? So the insurance companies feel that they're sort of protecting people from things that they may not know, because if doctors were allowed to just give you whatever they thought you wanted, we'd all be in surgery without, kind of trying to lose the weight first, or, trying to just, do what we could for ourselves first. So that's what I believe the insurance companies, from my experience with them, that's what I believe their rationale is. So I just wanted to add that just for y'all, so y'all can look that up, the House Bill 3459 for the state of Texas. So if you all get your claims and your coding and providers are submitting things on that on that Gold Card Act, you guys will be aware, because that's pretty new.
Appreciate it. Thank you. Now, look at Texas. That's one of the big states. That's one of the big. Those are some key areas, and if once folks latch in and get some stuff done in the big states, then usually the other big states follow, as well as some of the smaller ones. So that is very, very interesting. Very interesting. Mr. Jesse, did you have a comment?
I do.
I know you do. That's why I asked.
But before I start, could you put the Crafty Coders comment on the screen? Because this is what the exact same point I was going to make. Because as you were talking and as Renee was talking, both things can be true. The insurance industry is problematic, and also doctors don't do enough proper documentation. Because when you talk about pre-authorization and prior authorization, when you talk about a criteria, if just because the provider orders something, you still have to, it all comes back to medical necessity. Like, what did you document? Like, what you need to be able to demonstrate that this person needs X, Y, Z. And 2 wrongs don't make a right. But I'm telling you, like, I see it every day. Like, these doctors, their documentation is horrible. Like, I have never in my, like, how lazy are you to do an inpatient discharge summary? They have the admission diagnosis. Then for the discharge diagnosis, they copy and paste the active problem list as the discharge diagnosis, things that they never ever treated. And it's like you have to totally disregard that. Then if there's nothing, then if they don't answer it or address it in the hospital course section, which they hardly ever do, then you have to send 2-3 queries to get a straight answer, and then wait weeks and weeks days and days, sometimes weeks, for an appropriate response.
And it's such a burden.
How do you remember?
It's such a burden.
It is.
Let them tell it. It's such a burden just to write some clinical information that is helpful not only to the bottom line, but helpful more importantly to that patient's treatment and care. Such a burden. Go ahead, Renee. I'm sorry.
No, that's okay. But the more important thing is, if it's days and days, or maybe a week or 2 later, how do they really remember what that person came in? They see hundreds of people a day. So how do you really know if that's accurate, what you're writing, if you didn't do it in real time? The best thing is always to do your documentation in real time. As we know, as the nurse, you have to, if you didn't document it, you didn't do it. So this concept of days and weeks of added to someone's history, this is how people get diagnosed with things that maybe didn't have, or they did have and it was missed. And it creates a whole monster. And then and I know what you're saying, because even when they would submit things into the insurance, they would say, oh no, they don't have a past medical history. But then as you read and you listen through, or you read through what the person was complaining about, you'll realize, that sounds like a past medical history. If you have migraines, if you have, sleeping troubles, if you have, a history of not feeling, like you want to get out of bed and do anything, that's a sign of depression. I don't see a depression screen. And like, it's just so many things that seem small in the moment. And if they miss it, you could really do a disservice to your patient. And,
That's right.
that will affect the way the insurance companies view that medical necessity that person may need, because it'll say, well, will say, if we're not reading properly, or if we're just kind of skimming through and we're moving fast, the nurses at the insurance company would say, or the MDs at the insurance company would say, well, the doctor said they didn't have this, they didn't have that, so why is this medically necessary if there's no documentation of it? So that's very important, and it can get tricky for the person that really does need that procedure done. That's all I wanted to add. Thank you.
No, you're
Because
good.
I don't understand why providers don't understand how important proper documentation is, because improper documentation, really, you want to talk about burden, it is a huge burden on the revenue cycle. It can completely backlog the revenue cycle, because just like an example, like when I was talking about the doctor and the discharge summary, so many times, because these hospitals want to get these bills out right away, they put pressure on the coders to code these cases. So if they can get it through without having a whole bunch of specificity, because everything is about a DRG. So, and that's not all coding is based on. Coding is also based on proper coding and compliance. So, if somebody is inpatient and you have one provider documents acute systolic heart failure, then another provider documents acute on chronic systolic heart failure, for coding, you need to know which type of heart failure it is. So you have to query. Sometimes, like I had a case where it was chronic, and then in the ER it was acute on chronic. So I had to so chronic got billed. So I had to query the provider. The provider came back with acute on chronic, which is an MCC. Chronic is a CC. So the entire case has to be rebuilt because it was already billed. Like that creates a backlog.
And what the insurance calls fraud, waste, and abuse.
Well, it is waste because it's a waste of time, but it's just
Oh my
it just
God.
needs to.
Oh my God.
I mean, but it is. I mean, and like they swear they are so, and then you have to, like, this interesting part is, like, we have in our meetings, like, you have people like they actually you have to word things in such a way, or you have to make sure that when you're querying it's really something valid, because if they don't feel like answering it, they won't give you an explanation. Like, you should not have that you don't have the right to tie up healthcare's money because of you and your feelings. Don't become a doctor.
That's true. And to your point about the burden, not only on revenue cycle, but then you have this improper documentation, or not timely documentation, is also a burden on healthcare as a whole, the care and treatment to these patients. Then on that back end, if you have to fight for the pennies that you got, then there's an additional burden, because then where's that documentation, or what did you do? And to Renee's point, anytime I see some stuff that is way out of date, my compliance antenna goes like, what is this? What happened here? Why are you letting this happen? There should be policies. There should be policies and procedures starting in health information that clearly outlines and dictates, when things need to be documented, the timeliness of documentation. And then there should be some consequences related when it's not happening. And I think some of those things, and I don't know if it's because, we're the actual four walls of the department doesn't exist, and it doesn't necessarily have to exist to make this happen, but someone still needs to put a finger on the pulse of that and making sure that these providers are doing what the shut that stuff down. Something needs to happen to shut that down so they are not coming back 30 days later talking about, oh yeah, Miss Smith had so, sir, no, you don't remember what Miss Smith had 30 days ago. You don't. It's ridiculous. It's ridiculous. Ridiculous. So lively discussion. I love it. I love it. I love it. All right, let me tell you. So this is their ultimate strategy related to here. I think I'll share this screen, and hopefully we don't have this problem. I don't know. I'm seeing all kinds of things pop up about I'm seeing all kinds of stuff, but hopefully we'll be good. There's no audio or no video, so hopefully we'll be good in this. All right. So this is what they're coming up with as it relates to their so not only is it prior authorization, but utilization management is tied into this as well. And they're using the overarching theme of patient-centered care. So somebody has done a lot of homework and in tying all of these things together. So, they're tapping on the heartstrings of the American public. They're tapping on the heartstrings of patients. They're tapping on the heartstrings of providers and the burden and all of the things. So here's ultimately what they are wanting. This whole group, and it's a whole bunch of them that has signed off. You see on the left in the purple band, there's a whole group there. And then at the bottom, there's some more. So all of the supporting, it's like at least 3 pages or 2.5 pages and counting. So all of these providers are signing on, and this group strongly urges health plans, benefit managers, and any other party conducting utilization management, as well as accreditation organizations, to apply the following principles to utilization management programs for both medical and pharmacy benefits. And they're in different little segments. So first is clinical validity. Their first principle: any utilization management program applied to a service, device, or drug should be based on accurate and up-to-date clinical criteria and never cost alone. The reference clinical information should be readily available, to the prescribing/ordering provider and the public. Principle number 2, utilization management programs should allow for flexibility, including the timely overriding of step therapy requirements and appeal of prior authorization denials. Number 3, utilization review entities should offer an appeal system for their utilization management programs that allows a prescribing or ordering provider direct access, such as a toll-free number, to a provider of the same training and subspecialty for discussion of medical necessity issues. So that's that first arm in clinical validity. Any comments?
It's just clinical validity is really, it all comes down to documentation again.
Correct.
That's the meat and potatoes, because that's how you validate anything is through documentation.
And so if you don't have documentation from these providers, where is what? Okay, I'm
right.
you right there.
Will be denied. They'll be denied, and then a lot of people don't even know that they can request their doctors have an appeal or a peer-to-peer, and they are different. An appeal is different from a peer-to-peer. So there's a certain amount of time that your doctor, if your claim is denied, there's a certain amount of time that your doctor can have a peer-to-peer, which means that they're going to go and speak to another doctor from the insurance company to explain the process and what happened, and basically verbally give the documentation. And then that doctor at the insurance company will determine if, okay, that stay or that procedure or what have you is medically necessary. Then they can overturn it and it'll go through with your claim, or they can leave it upheld, what they call uphold the denial. Appeal process, that's totally different. It takes longer because the doctor missed the window for the peer-to-peer. So a lot of people don't know that they can call in and ask their insurance company, hey, I had this, I was in a hospital, I'll just say inpatient, I was in a hospital. I got a denial saying, it wasn't medically necessary for however amount of time. The person can actually ask their doctor to go back and follow this process. But sometimes doctors will, kind of drop the ball. They can, because they're so busy, they can drop the ball and not do it. And now that person is stuck with the bill, which is really the sad part, because they're still responsible, whether it goes through the insurance or not. That's what people don't know.
That's what they need to. That should be another piece of what doctors wish patients should know. Ultimately,
Absolutely.
You may have to come out your pocket.
Absolutely.
The next piece is continuity of care. So principle number 4, utilization review entities should offer a minimum of a 60-day grace period for any step therapy or prior authorization protocols for patients who are already stabilized on a particular treatment upon enrollment in the plan. During this period, any medical treatment or drug regimen should not be interrupted while the utilization management requirements, example, prior authorization, step therapy overrides, formulary exceptions, etc., are addressed. Principle number 5, a drug or medical service that is removed from a plan's formulary or is subject to new coverage restrictions after the beneficiary enrollment period has ended should be covered without restrictions for the duration of the benefit year. Principle number 6, a prior authorization approval should be valid for the duration of the prescribed or ordered course of treatment. Principle number 7, no utilization review entity should require patients to repeat step therapy protocols or retry therapies failed under other benefit plans before qualifying for coverage of a current effective therapy. Transparency and fairness is the next group. Number 8, utilization review entities should publicly disclose in a searchable electronic format patient-specific utilization management requirements, including prior authorization, step therapy, and formulary restrictions with patient cost-sharing information applied to individual drugs and medical services. Such information should be accurate and current and include an effective date in order to be relied upon by providers and patients, including prospective patients engaged in the enrollment process. Additionally, utilization review entities should clearly communicate to prescribing or ordering providers what supporting documentation is needed to complete every prior authorization and step therapy override request. But they be asking for stuff that they ain't even willing to do. Number 9, utilization review entities should provide and vendors should display accurate, patient-specific, and up-to-date formularies that include prior authorization and step therapy requirements in electronic record systems for purposes that include e-prescribing. 10 is a whole utilization review entity should make statistics regarding prior authorization, approval, and denial rates available on their website or another publicly available website in a readily accessible format. The statistics shall include, but are not limited to, the following categories related to prior authorization requests: healthcare provider type or specialty, medication, diagnostic test or procedure, indication, total annual prior authorization requests, approvals and denials, reasons for denials, such as but not limited to medical necessity or incomplete prior authorization submission, and denials overturned upon appeal. These data should inform efforts to refine and improve utilization management programs. And then 11 in this group, utilization review entities should provide detailed explanations for prior authorization or step therapy override denials, including an indication of any missing information. All utilization review denials should include the clinical rationale for the adverse determination, for example, National Medical Specialty Society guidelines, peer-reviewed clinical literature, etc., provide the plan's covered alternative treatment, and detail the provider's appeal rights. I was like, wow. Again, there's a lot of things in there that they're asking for that I don't even know that they do or want to do, especially some of that transparency as it relates to, well, yeah. This was real interesting to me. Timely access and administrative efficiency. I think this is rounding out. There might be one more. Number 12, a utilization review entity requiring healthcare providers to adhere to prior authorization protocols should accept and respond to prior authorization and step therapy override requests exclusively through secure electronic submissions using the standard electronic transactions for pharmacy and medical service benefits. Facsimile proprietary payer web-based portals, telephone discussions, and non-standard electronic forms shall not be considered electronic transmissions. Number 13, eligibility and all other medical policy coverage determinations should be performed as part of the prior authorization process. Patients and physicians should be able to rely on an authorization as a commitment to coverage and payment of the corresponding claim. 14, in order to allow sufficient time for care delivery, a utilization review entity should not revoke, limit, condition, or restrict coverage for authorized care provided within 45 business days from the date authorization was received. 15, if a utilization review entity requires prior authorization for non-urgent care, the entity should make a determination and notify the provider within 48 hours of obtaining all necessary information. For urgent care, the determination should be made within 24 hours of obtaining all necessary information. Number 16, should a provider determine the need for an expedited appeal, a decision on such an appeal should be communicated by the utilization review entity to the provider and patient within 24 hours. Providers and patients should be notified of decisions on all other appeals within 10 calendar days. All appeal decisions should be made by a provider who is of the same specialty and subspecialty whenever possible as the prescribed ordering provider and was not involved in the initial adverse determination. Number 17, prior authorization should never be required for emergency care. Number 18, utilization review entities are encouraged to standardize criteria across the industry to promote uniformity and reduce administrative burdens. There's that word again. Alternatives and exemption. 19, health plans should restrict utilization management programs to, quote, outlier providers whose prescribing or ordering patterns differ significantly from their peers after adjusting for patient mix and other relevant factors. 20, health plans should offer providers practices at least one physician-driven, clinically based alternative to prior authorization, such as, but not limited to, the Gold Card, hey, there you go, Texas, or preferred provider programs or attestation of use of appropriate use criteria, clinical decision support systems, or clinical pathways. And lastly, 21, a provider that contracts with a health plan to participate in a financial risk-sharing payment plan should be exempt from prior authorization and step therapy requirements for services covered under the plan's benefits. So yeah, all these people are in agreement with those principles, and those are part of the shots that are being fired for against insurances for prior authorizations. Y'all got comments? Like, where do you begin? My
comments want to be brief, and then I'll just yield to Renee. Some of it is true. Some of their points I can agree with, but overall, I don't like the tone, because overall, it's still about catering to them. Because what are they going to do? Now, what needs to happen is the insurance industry needs to come out with that same document, but have 22 points, and they should all say, make sure you document what you're trying to ask us to pay for. They should submit 21 points and put that, and then say refer to the 22nd one should be referred to the first 21 points I made. That should be their document.
I need my tea.
Because they asking a whole lot, but they don't want to do anything. All you want to do is copy and paste all day, but you want people to lay things out for you.
That's the truth. That's
the nerve.
That's the truth.
I'm
When I
done.
read
Go
all,
ahead,
I
Renee.
said, "Wow, wow!" And again, there's some money at the AMA. There's some money. The money is flowing over there at the AMA, getting all of this together. And if you sit back and kind of look at the whole picture, the big whole picture, they're getting all their ducks in a row to make this happen. They're pulling the things, but again, I haven't heard the opposing side, so I don't know what's happening as far as the insurance industry. I do hear a little sprinkling of some of these principles occurring in what is being done on a regulatory level, because CMS has sort of jumped on some of this bandwagon and some of the things that they are reintroducing some of these managed care plans to do, letting them know, hey, you're not different. You're supposed to be doing some of the same things that fee for service Medicare is doing. So this is going to be a real interesting turn of events as we move forward. Real interesting. Mm-mm-mm. All right, so let's turn real quick to these nurses.
What
Oh, go ahead.
before we get it, I wanted to address. I was going to leave room for Renee to comment, but maybe she's not able to. But
Oh no, I'm here. I was
okay,
gonna say from my experience, the insurance companies, I would say they follow for the most those rules and guidelines. They do have a standard where they do try to get the turnaround times within 24 to 48 hours. However, you have to think staff, you have to account for weekends, you have to account for what state laws follow. So I know I'm gonna just use Texas for instance. Texas, they go by calendar days, whereas Illinois goes by business days. So you have to know the laws of the state that you're working in, so that you'll know what 24 hours really does mean, and what 48 hours really does mean. And then everybody says everything is urgent. So really and truly, how do we decipher versus what's urgent from what could be maybe not non-urgent? So it's not fair that everybody, because you knew that a doctor knew that a person had a musculoskeletal issue. Chances are, if they have it in March, they had it in December. So no one said that you couldn't start your process early to get your prior authorizations done, to get your reviews in, to get the documentation to us, to the insurance providers, to make sure that this procedure was going to be medically necessary before you scheduled that person. And now everything is urgent. Oh, no, 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 they need to go, but haven't they been having these same pains and aches and different ailments since
For
December,
years.
or even yeah, for years.
Years.
So why did you wait till March when you want to do the procedure to tell us, oh no, I need this in 3 days? Like, really? And
Exactly.
those types of cases can be up to 15 days. It just depends. So I think that the company that I had worked for, they were really good about following the majority of those bullet points that you offered, Clarice. They were really good about following that. But sometimes it's just not possible. Sometimes you don't have the staff to work. Sometimes you don't have the providers sent it today and now they want it tomorrow. So what about the people that were standing in front of you waiting patiently, and you think you can just kind of skip the line because, oh, but this is urgent? And so it really does have a lot to do with the physicians. They really need to have their process is just streamlined a little bit better in certain areas. And that's what I'll say about those bullet points. But utilization is it's a very big concern, because like I said, for different companies, it's fraud, it's waste, it's abuse. They call it different things, but essentially it's saying the same thing. How do we manage what is truly necessary versus what could be handled on a more routine basis? Is that really an emergency? Is it really, how urgent is it? And I think that that's a lot to do with it too. We have to decipher, because to everybody, your clinical judgment would say, yeah, that's urgent. They're in pain. They've been in pain for 2 years. Okay, so like to Jesse's point, why aren't you documenting for 2 years they've had this pain, so that it'll make it easier for the reviewer to say, oh yeah, I can see, now it's escalating to numbness in the feet, or it's escalating to neurogenic bladders or something like that. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. But if it's urgent, then we can kind of, we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. So we can kind of see the deterioration, and okay, yeah, okay, they probably do need to see a doctor. need this procedure. But if you're not saying anything about that, oh no, they're not having difficulty voiding. Oh no, they walk just fine. They don't use any assistive devices. Okay, then is it really urgent? So words matter. That's all.
Yep. And burden or not, it is that provider's responsibility and part of their job to paint that picture of that patient to anybody who is reading that documentation. That is their job.
Yeah.
Period. And another point, you can't paint that broad brushstroke across everybody. So it's not that things are done from a federal level. To your point, states have different rules and regulations. States operate a little different.
Yeah.
And so sounds good on paper and in bullet points to do this and that and the third, but everybody is and trust me and believe those states will fight. The states will fight.
They will. They are.
Before we move on, I want to make one more point before we leave this topic. Did you notice in that video that you played that they talked about fighting against scope creep?
I saw it. That was number one. That was number one.
So while we were talking, I'm like, because I'm like, I think I know what they're talking about, but I want to Google it to be sure. So I went back to the AMA website, and they have a whole page, and they really are. I'm like, here they go again, taking shots at the nurse practitioners. I'm like, leave them alone.
They are part of that whole plan. Nurse practitioners, that's their thing. That's their jam. So they're again part of that list of things that are in their plan to address,
right.
To help the poor, overburdened physician provider. Yeah, I saw that. I said, oh, wait a minute. I said scope creep. Wait a minute. That's targeted at somebody. And again, they got all these dollars and cents to help them in that endeavor. And we may take some time in the coming weeks to really go through and see what the plans are as it relates to that scope creep. That'll be fun. But changing this other foolishness is not helping the fight. Let's start there. This other foolishness. So we all know about the Nightingale sweep, and that there were 10, I believe it's 10 medical schools nursing schools, my bad. 10 nursing schools that was giving out bogus degrees and allowing folks to take these tests and the whole debacle. Well, in an article a couple days ago from Erica Carbajal, hope I didn't butcher her name. I know how I feel about names. They are saying that these nurses are now lightweight. Like, wait a minute, hold up. Just because I went to that school doesn't necessarily mean I did something wrong. So people they're getting side-eyed because they went to the school. And I believe that a lot of these healthcare organizations are kind of digging in and like, well, let's take a look at some of these new nurses that we've hired, or maybe some of these old nurses who may have gone to these schools and received their training. So so some of these nurses are getting attorneys, and the attorneys are like, wait a minute, hold up. I got nurses that have come to me and stated, we did what we were supposed to do. We went to our classes. We did the coursework. We did everything. So, I guess just in case they get these attorneys on retainer to help them fight. Then you have a whole group of nurses in New York that have hired attorney Jordan Finsterman. And he said some of the 40 affected nurses that he is representing or speaking for, many who are immigrants, he was real clear to put that in the article, claimed they attended their classes as well. But then they flew to Florida for training and then participated in this New York-based exam prep program that was affiliated with the Florida schools. And so all of that is tied together, which now is allowing the folks to give them the side eye because they were part of the schools that have now either been closed or forced to close, voluntary closed, or voluntold closed, or pausing graduation and enrollment. So yeah. Was you gonna say something? I'm sorry.
No, go ahead.
Okay. So that is just an update on what's happening. So, you know, some of these nurses are like, wait a minute, time out. I did my part. You know, don't lump me into the sale of all of these degrees. And so it's going to really take some more time, because at some point somebody is going to have to really go through and kind of individually look at these nurses and their credentials to determine the legitimacy or not. But so, because we talked about this before, because it was like, well, they're not necessarily going after the nurses, but are they? And maybe there's a plan to do that.
I'm not really sure.
Because why all this energy? Why all this energy?
Right. Because because then it becomes a legal issue as opposed to an ethical issue.
Right.
Because legally the school was accredited.
Yep.
But ethically, you know that these people did not complete a program.
Right.
You gave them a document for money. They did not complete 24 months. They did not complete 18 months. Some of these people never attended a class at all. Just a prep class to take the NCLEX.
Yep.
So I'm not really sure how that's going to flush out, because if that's the case, I'm going to find a school tomorrow and become an RN by next Saturday. If it's going to be done like that, and then they can keep their license, I mean, what is the incentive at that point?
Well, so in another article or something that I looked at, they were quoting some of the statistics of the nurses leaving, that they don't have enough nurses, or enrollment rates and this was probably a couple of years ago, were down. You don't have enough staff at these nursing schools to teach and train nurses. I mean, they're, you know, it's the big nurse migration of 2022, 2023. And so it's like, so what do you do? How do you weigh that? And so that also becomes part of the conversation as they go forward.
Oh, but see, but here it's nowhere near as hard as they're making it out to be. They're making it's hard. They're making it hard because at the end of the day, they still want to gatekeep. You know, we haven't used that word in a while. But the problem, the problem with nursing has always been that it is gatekeeping by white women. They have wanted to maintain power and control. They have these outrageous requirements for people to get in these programs. Then they get in programs and they don't provide the proper support. They have favorites and they make it too difficult for working people to complete a program. There aren't many people out here most nurses who are going to school are not 18 and live at home, and their parents take care of them. These are people who have families, jobs, obligations, and it is the whole process to become a nurse is entirely too cumbersome. And it is also too cumbersome to even transition from an LPN to an RN. That should be one of the most easiest transitions to make in all of healthcare, but it's not. And that's intentional. And it's intentional because you have RNs who still to this day have a negative opinion of LPNs.
Mm.
So it's a whole lot of things that are going on. And the bottom line is the industry is falling apart because the people who have created it and ruined it are now 60 plus, 65, 70 with bad knees, bad hips, and they can't do it anymore. Plus the computer that ran them off. So they scared to log into Epic. So now it's falling apart because they did not create a funnel for the next generation to come up under them. So I'm glad. Let it fall apart. Let the janitor pass some medicine and hang an IV because they bought it on themselves.
Oh my God. So we
And
got
to
gatekeeping
your
on both
point,
sides. Go ahead. I'm sorry.
absolutely. Oh, no, no, no. I was just gonna say that was spot on. I couldn't have said it any better. That is absolutely true. Um, and remember, I think we're getting away from the very beginning of, if we go back to the history of nursing, when people nursed in the wars and different things like that, what education did they have? It was a trade. Nursing used to be a trade. And so you didn't need all this
Hmm.
education with, books and communication and philosophy and English and all that kind of stuff. You didn't need that because you were there to, like, just say it, hang an IV. What does me knowing how to communicate have to do with me being able to hang your IV? Now, is communication important? Yes, it is. I need to be able to say, "Hi, I'm Renee. I'll be your nurse. I'm going to hang this IV for you." But in the trauma of it all, are you really caring what my name is, or do you want me to get the IV hung? So it used to be a trade. I think that's a big thing that has gotten away from us. They made it so hard for nurses that do want to educate to go back. You need a master's degree, you need a doctorate degree. You made it such a business of education that you can't actually focus on the skill and the care that nursing really should be. And so now when you have, like, just, that's a good word, the gatekeepers that said, well, no, LPNs can't do this. Why not? LPNs can do everything we can do except the blood, and I believe the Vanco in the secondary settings. But pretty much we all can do the same thing. We're all trained the same way. They know the same information, it's the same anatomy and physiology. It's the same chemistry. It's the same biology. We take the same classes. So
Mm-hmm.
there really shouldn't be a difference. But the thing is, all back to a skill. LPNs, you could go into a hospital, even I think as far back as the 70s or as recent as the 70s. You could go into a county in Chicago, the Cook County Hospital, and say, "Hey, I'm interested in being an LPN." They didn't send you to school. They said, "Okay, you're gonna go through this program for the next, what, 12 months, 18 months, and you're gonna learn these skills, and then you're gonna come and do your job." That's it. So I think just making it so heavily inundated on, "Oh, you need this education." Yes, those classes are important. Yes, it will behoove you to understand the chemistry so that when you work with pharmacy, you understand those chemical compounds and how they're going to break down, and the physiology of what's going to happen in your body when you take certain medication. That would be helpful. But at the end of the day, that's pharmacy's job. I'm not a pharmacist. So to make me responsible for what the doctor, his documentation, make me responsible for the medication, to make sure that that person is not allergic, and make sure the pharmacy did what they supposed to do. Nursing just has too many busy tasks that, don't get me wrong, are important. But at the same time, we can't necessarily focus on the healing and the survival and the well-being of our patients, because we're just inundated with other tasks. And now, to compound that, it is education, because that's a financial stressor. And if you're already working to make your life meet, what are you going to do with more student loan debt? Or, like Jesse said, you can't even get to the program at all because the hours don't work for you. And it is filled with, I had to quit my job to go to nursing school, but I was just fortunate because I had help. And so if I didn't have that help, would I be a nurse today? It's just so, our lives are just not the same as it was when nursing was first a trade.
Mm-hmm.
And it has just derailed from that. And that's what I'll say to that. It's derailed. And Jesse's right. The gatekeepers have made it that way. They don't want us there. That's why they go out of their way sometimes, in some instances. You have to work med surge first. Oh, you can't come to the ER. Oh, you can't come to labor and delivery. Oh, you can't come to ICU. Those are considered the specialty areas, and that's what some people don't want other people to have on their resume. Oh, yes, I could be an L&D nurse. Oh, yes, I could be, ICU. I can hang in these drips and these ventilations. I can understand the PEEP and just the settings that the ventilation's gonna need. Well, in COVID, I bet you could have used anybody that could have had that experience, but for so long, we were kind of held back from those positions. Now you really need the help. And so it's not that it's a shortage, it's a shortage of skills that you want to offer once the nurse graduate. When I first graduated, I was an LPN. When I first graduated, I couldn't get a hospital job because they were saying they want the magnet status and you need a bachelor's degree. And you definitely need an RN degree. And it's just like, okay, let me go back and get that. And I did that. And they're still telling me, oh, you need a master's degree for this. You think I'm going to go get a master's degree to work the floor when it's a trade by trade, by history? This is a trade. It could be considered a trade, just like wood shop, just like electricians. Like, it's a trade. You're gonna physically be doing a job. It was a time you went to school to get your bachelor's degree if you want to get to management.
Yep.
You want to sit in meetings and write letters and emails and things like that. That's when you got the schooling. But to do your job, it just it's a lot. So I agree 100% with you, Jesse. It's a lot, and it doesn't take away from what people actually can be good nurses. It's sad. So yeah, who says the education is the determining factor why some, if they went to the state and passed that board, what does that tell you? Because school accreditation or not, however long they took those classes or not, if they went to the state and took that state exam and passed, and the state of that Florida gave them a license, what does that say about the educational system? Everything needs to just be looked at. And yes, there's a process, and yes, there's a standard. So what they did was wrong. I mean, but like Jesse said, what are we? Are we law? Are we lawyers now, or are we ethical? And if you're going to do it, go ahead and do it right. Follow the rules, because that's the thing that you'll miss. If I know, for me, we went to a good school, and our educators were very, very, very serious about us being prudent nurses, and about us not being robotic. And make sure that you look at your patient, you assess your patient, you know what's going on. I don't care what a doctor says, what another nurse says, you need to know. And so you miss that key core value that has to be developed and like sewn into you. It's some things you really should go to school just to get, so that you'll respect what you're doing. These are people. Although we talk about numbers and the codes, and those are numbers, but at the end of the day, we're talking about people who are probably at the worst time of their life going through it. And all we can do is say, oh yeah, the doctor didn't document that, so you can't have this. That's wrong. That's wrong. So the whole system does need a overview and an overhaul. I would agree. Yes.
And to really just come back to what Renee was saying, because that's you made excellent points. But the main thing is, like you said, nursing has always been a skill. Nursing, yes, according to the Department of Labor, is skilled labor. Yeah. And the gatekeepers, we know who they are. Absolutely. They have been trying to elevate nursing to a profession. That's where all this education is being required. But in their pursuit of education, they have lost the skill.
Yes. And the overall calling of it all. It shouldn't be that, oh, I'm going to be a nurse because I want to be a professional. That's a calling you got to have to see somebody sick as people, and people are sick on the next level. Yes, not even like how they were 100 years ago. People are sick. So in order for you to take that, you have gunshot wounds, and it's one thing to hear it on the news. Oh yeah, in Chicago they're shooting, and but when you actually have to see a gunshot wound in someone's head is not anatomically correct anymore, and someone's limbs are just all over the place, like that's traumatic for us. Mm-hmm. So when we have to put that to the side, okay, this is what it is. Come on, go into survival mode. We got to help these people. And now you just, it's easy to become robotic with that, because it's just like, okay, get the blood hanging, put the oxygen on, just, you become robotic, but that's still a person. And you still have to have some sort of level of empathy in your heart for this profession or this skill or whatever term and I guess label they want to add to what we do. You still got to have a heart for it. And at the end of the day, nobody can teach you that. That has to come from within. And if it doesn't, stay away from the professions, from the skill. Don't do it, because they'll say, the nurses make money. Everything is not about money, because your peace of mind, sometimes people stick with you. Certain cases stick with you, and that becomes mentally draining. And who do we talk to? Because if you're not a nurse and you're not in the medical profession, who really understands what we go through? All you see is money. All I hear people say, oh, money, money, money. No, it's not about money. You got to have a heart for it. You really should have a heart for it. Let me say that, because some people don't, but you should. You should. And those are things that the proper teachers and the proper educators can help you understand. If it's not for you, stop now. Don't waste time. Just go find something else to do. But that's what I think school is important for. But you have to have the right educator, because I've had some good educators and I've had some that not so good. And you know, what do you do with those? Well, what are we doing about those people? Because those people need to be looked at too. Why are you still in this profession if this is your behavior and you're an educator? That's an important job. You teaching the future generation, and your I guess tone and your thoughts and your concept, you will lead with them whether you mean it or not. It's a seed they're sowing. So if you don't want to be in education, don't be in education. Like, just don't do things that you know in your heart, oh, I'm just doing it for money. Don't do it. Just find something else. It's 100 different ways to make money. Don't be a nurse for it, because now you're, it just, don't do it. That's all.
And this is, I love this conversation, and this is applicable across the board. Especially the conversation about how you're taking something that is a skill, and because you want to add it to be perceived as a professional in using those skills, and you apply these additional parameters such as having the degrees, having the certifications, having the additional experience and training. Now you are where it always started out as you had those gatekeepers, and it seemed from back in the day, the white men were the gatekeepers of the physicians, and the white women were the gatekeepers of the nursing. So now they're taking it and even fragmenting it even further. So you got, okay, well, we done segregated y'all into these little niches. So, LPNs, this is where y'all gonna be. And yeah, you are the skill, the laborer, the whatever. And we're going to continue to treat you as such. And we're going to block and gatekeep where you can't no longer advance in certain areas. So we're going to keep you in nursing facilities. We're going to keep you in those places that are, we ain't working there. I'm not, who doing that? Oh, send the LPNs down there. They'll do it. And then they're so overworked and underpaid in those particular physicians, but it's more than what they had. So some of them may be happy with that. So then they're okay. Well, maybe you get a few who climb out of that and they get their RN and maybe if it's an associate RN. Oh, you still not good enough because you still don't have enough quote unquote education to be sitting over here with us. Really? To both of your points, I've taken the same courses. I've taken the same AMP. We looking at the same body, pharmacology, all of the things. So why is it still not enough? Oh, so they're waving this carrot or dangling this carrot to get you to spend more money or put in more time to frustrate you, to maybe even make you just leave the profession altogether, because this is about us. This our profession, and we're going to make sure that we keep the reins on this profession and we do what we do. God bless all of you all who are making bounds and leaps out of that. Even to health information, we got the same. When y'all were talking, I was seeing the same similarities coming up through how things were started with the medical librarians, the little white ladies with the buns who were gatekeeping in their area. Folks didn't even realize that there were opportunities for you to be in medicine, but not be in medicine. But because they were behind these closed doors and this is what they were doing and getting paid doing what they did. You know what I'm saying? Nobody knew nothing about that because they was funneling everybody over here into the trade or into the skill, not knowing that there are other skills that are necessary to run this thing called medicine. Oh my God, we could be here all day.
I could too, and I want to speak to that, Clarice, because you're right. we don't even realize that you can actually edit medical journals. Like you're right. It's so many things that you can do that you don't have to actually have to physically touch your patients or anything like that. You can just review for different companies, review the medical policies, and create medical policy. It's so many things that you can do that probably at that time didn't require much education, but they don't share that in our schools. So when our children are deciding to take biology classes in our schools, we're not taught that what you can do with biology, that you can go and study marine life. It's life in the water. We don't understand medical terminology that the term bio is life. So when you're talking about the biology of something, you're talking about the evolution of it from the caterpillar to the butterfly. Why is that important? Because, my dear, you are the caterpillar, and one day you will be a butterfly. So what are you going to morph into? What is your calling to do in life? So I think that we take these hard subject matters and we don't discuss it enough with our kids. And that's important too, because we have to know that there are so many cool jobs that really, now that they may say you have to have a degree, but back then you didn't. But it's okay, because now we can create our own. And one thing I have learned by one of my mentors, Dr. Davis, he has taught us, you don't have to know what to do. You just have to know how to get it done. And at the end of the day, that's what we have to figure out. We don't have to take these, traumas that they place on us because we need to work and we need to make money. It's 100 different ways to make money. You take what you know and you sow it into someone else, and then we can all, come back and be a community and keep our money the way the other coaches do. And that is the takeaway of it all. To me, that's the takeaway. Do what we
Amen.
know, share what we know, and then build on what we know, and don't look for nobody else. Because we make money. Black people make money. Let's be clear. We don't have a making money problem. We have a how do we sow it? How do we invest it? How do we get a return on the money? Because we make it and then we spend it. But who are we spending it with, and what are we spending it on? That's
Mm-hmm.
important. So that's all I wanted to add, is that, yeah, you can be a medical reviewer with like a journalism degree, or like if you like to read and write, you can review for these terms. And if you maybe take a medical terminology class, you'll be good to go with some money. You have a job, and now you're a healthcare professional.
And that's why I'm
Look at
so
that.
intentional about when talking to young people, and not necessarily asking them the age old question, what is it that you want to be when you grow up? um my questions are usually, what are you passionate about, what are you interested in? Because some of those things that folks would normally throw out, oh, I want to be a doctor, I want to be a teacher, there are a lot of professions, or a lot of uh, jobs, if you will, that didn't exist back then. People are creating new jobs every single day, just based on the skills and the things that they bring to the table. Oh, you do this, that, and third. Well, we need somebody to do this, that, and third. Voila, we have created a whole new profession or a whole new job. So don't box people into thinking, oh, well, you just got to do this. You have this skill, you're passionate about this. Well, just push them over here. No, let them expand. Let them imagine and create and think about what may not be in front of them, because there will always be, and we're living proof of that. We see how things have transformed and morphed from 10 years, 5 years, 2 years, a year ago. Things are different, and they continue to be different. And as our young people are coming up, they have a whole different skill set that we may not necessarily have and know, because again, they were have been walking around with computers in their hands for years. They know all of the things. And so again, and their perception on what that future looks like is a little different than what we have. And so we just need to make sure that we're pouring into them. Yes, give them the skill, give them what they need to go after whatever it is that they're trying to do. But ultimately, let them know that you don't necessarily even got to rely on somebody else. You can be that owner. You can be that entrepreneur and employ others. You can be the one that is pouring into people and advancing wherever the profession is that you're trying to go. So yeah.
Can I ask you this question, Clarice? This is HIM related.
Okay.
Because I see something that I always suspected, but I just couldn't. I was like, how is it being done? In your opinion, being the experienced woman you are in HIM, do you think that a person can complete a 20 to 40-hour online course to be effective in CDI?
Yes. It depends on what that course is made up of, and what the key points of that course is. If they are skimming the surface, probably not. But if they're going deep in that course, if they're doing some case studies, if they are going practical examples, if they are really digging deep, if and it really depends on, again, who structured that course, who's teaching that course, and their level of experience in that thing. Yes, I do.
So in 20 to 40 hours, you can understand the inpatient prospective payment system, the ICD-10 CM code set, the ICD-10 PCS code set, and MSDRGs and APRDRGs.
I believe you have an understanding. So your course may be 20 to 30 hours, but remember, there's coursework outside of that requires additional study. So there's additional time. And as things change, we all know things change every year in our profession. It's a lifelong learning. So yeah, you're getting that introduction. You're getting enough to have a broad understanding of that information. And again, if you want it, you're gonna study it. You're gonna know it. You're gonna master it. And so yes, I believe that that's to be true. Now, I don't think everybody can do it, but yes, if that's your goal, and if that's what it is that you want to do, I think so. And to the crafty coders point, it depends on where they're starting, because some of them, you can't just jump into a 20 to 30 hour course not even knowing what medical terminology is. No, so some folks is not, that's not their jam. Some folks, you got to gauge the level of knowledge and information that person coming into that class or course has. And no, ma'am or sir, this one may not be for you. This may be too advanced, and so you may have to step down, which will require additional time. But an educator will provide that information. And an educator won't be about trying to take somebody's money. Oh, yes, you got an interest, let me take your money. And then you frustrate the person and push them completely away because they feel like, oh my God, I've spent this money. I gambled and whatever. When an educator will tell you, sweetie, this one, this may not be for you, or you may need additional whatever. So it just depends, because they do these boot camps all the time. And folks are coming out of these boot camps with that are about 40 hours. They do a week worth of information and training to get people to pass their certification exams. They do it all the time. But again, it's with that person's knowledge and what they're bringing to the table. Now, if you're somebody brand new, spanking off the thing, probably not. But if you've been following this, if you've been learning this, if you've been talking, if you've been in the trenches, then there's an opportunity there.
Because I really wanted your opinion, because I think the exact opposite. I don't think it's possible, because I said to be effective, because I know somebody who went through a boot camp and they're still clueless, because the boot camp didn't really address core concepts. Because,
and that's that person's problem. Not to cut you off, that's that person's problem. Because if you're not getting what you paid for, I paid for a service. I paid for you to get me where I need to be. You are the conduit from point A to point B. And if I'm not getting what I paid for, that's on me. I need to ask the questions. I need to make sure, well, wait a minute, what about XYZ? And sometimes you got to do some of your own additional research and information gathering to even be able to know, well, what questions do I need to ask? But you got to know what your end game is. We have multiple people who ask us on a regular basis, even in this forum, well, what do I need to do? Should I do inpatient? Should I do physician? They have no idea. They just hear this broad term, and it's like, well, this broad term and these different certifications, and figure, oh, I'll just jump in here. No, differences in all of this, but you need to know what it is that you're passionate about and what it is that you need to do. And that way you can make an informed decision and be an informed buyer of the thing, which is the course, that will advance you to where you need to be. And oftentimes folks are not. And that is one, unfortunate, but let that be a reason why you do the due diligence up front to understand. But then also to your point about while you think that they don't have it, I think again, this is lifelong learning. You start and you build. So you that course, that boot camp, that whatever, if this is where you're going, that's your foundation. You don't stop there. You are always learning. You are every single day. There is something that you are learning related to our profession. Again, because things change all the time. So what I knew yesterday may not even be applicable tomorrow. And so you have to make sure that you're staying abreast and understand. What you need is a firm foundation on where do you need to go to get information? What do you need to do in order to make sure that you understand how to get the information? Because that's the whole key in coding and health information, and then staying abreast of that.
See, and
in my opinion,
I don't. Right, because I think it's hard to put the burden on the person who's taking this course, because all these programs say the sun, the moon, and the stars, all of them.
No, and you're right. You're right. That it's not just on them.
Right, and you don't realize until after the fact that you then got. And what was interesting is we had a meeting at my job, and somebody had completed the actors apprenticeship. When she described the actors apprenticeship, I'm like, oh, well, she don't know nothing. Like they introduced. She said they introduced concepts like, oh, okay, well, introduce it. Okay, it's nice to have the concept of a DRG, but if you don't know that the MSDRG is used by CMS and the APR-DRG is used by other payers, and this CMS is based off of CCs and MCCs, and APR-DRGs are SOI and ROM, and they both have 4 levels that you need a grouper to compute, but you can actually compute an MSDRG manually using some manuals. I just don't know how you go about doing your job effectively when you, as the CDI, it is your job to establish a working DRG using these guidelines, knowing that sometimes a medical case can turn into a surgical case based off of this procedure. And then you also need to know how to code this procedure accurately to get the grouper to give you the correct DRG for that case.
Now, is that regular knowledge that one key component of working in CDI is that you need to have that level of information? Because
absolutely,
oftentimes they provide you with levels. They provide you with, okay, well, this is all the information that you need in order to in this case, be an apprentice. Now, they don't deep dive into what that looks like. They're just giving you, again, that surface information. And it's up to the person to say, well, wait a minute, if I need to know how to compute all of this, where is that being taught on how I do that? Or is it, oh, we got tools and software and this, that, and the third. All you just need to know is if you put A and B together, then you can get C. So again, it's a conversation. It's an evaluation between whoever is, hopefully it's a conversation and evaluation between whoever is putting together those courses and that course material with the person who is now interested in coming in. Unfortunately, we live in a place where, it's where the money resides. Folks are about the bag. Hey, you got a desire? I can teach you. Let me teach you. But they're not even providing them with the information and the necessity or the necessary information that they need to advance. And again, some of that takes into account that person. What is it that you want to do? Because you may go through all of this and be like, well, I don't even want to do that. I thought it was XYZ. And all of that could have been avoided had there been a conversation, had there been some sort of, well, let's make sure we talk to, for me, for example, when folks approach me about my class, first of all, I tell folks all the time, I'm not for everybody because you gonna work, number one. But number two, I need to assess. I need to have an understanding of where you are while I have an overall program that hits all of the different areas. I need to assess where this person is, because ultimately I want to see you win. I don't want to take your money and then send you out there. Good luck. Carry on. No, I want to see you win. I want to see you get the information. I need to see, for me to know I did my job, the light bulb come off on your face. Oh, you got it. Okay. And from there we build versus, oh, well, I told you. Well, then you should know. Well, no. And so again, to me, it's my job to make sure that I'm not setting folks up for failure. And most people shouldn't do that. But unfortunately, you and I both know they're not only individuals, but even whole organizations that their goal, they have a sales goal. Get them people in the door. Get the people in the class. Get the people. And then it's like, oh, well, we told you, or we gave you the syllabus, or we whatever, without even having a conversation to really understand what that student needs. Keep in mind, folks learn differently. You have to account for all of that when if you are an educator. Let me just say that. If you are an educator and you really, really are about the business of providing information, you gotta know all of that and have those conversations with the person and be honest. You know what? I know you done already wrote the check and put my name on it. And I know you want to give it to me, but I'm not going to take it because you're not ready. I'm not going to take it because I feel like there's some additional steps you need to do. Now, I can help you in those additional steps, but this course right here, this ain't for you. It's not for you. And you're going to waste your time and you're going to waste my time because then I'm going to be frustrated because I can't get to you. So again, I think, to your original question, yes, it can be done, but there's a whole lot of factors that need to be in play to do that. And there has to be some conversations and understanding on everybody's part to make sure that the person who is spending that money gets ultimately to the goal that they're trying to get. So what is this apprentice program? Is that to help them get their certification, or is it just to build knowledge for them or give them an introduction? I mean, what does the active apprenticeship do?
What I'm finding out is that certain places with that apprentice designation, they are hiring people into CDI roles. Well, and that's mind-boggling to me.
Wow.
I don't know how you do that.
So is it a nursing thing, or is it because they want the clinical people to be able to just slide right in, or is it
it's
the health information people?
I think this is really mainly clinical people, but the majority of the clinical people are like this, not like.
Oh, I understand. Gatekeeping 201. Like, okay, well, we know we got all these people who are coming with this, that, and the third, but let's create a different pathway to get them to XYZ. But to your point, ultimately, I mean, somewhere somebody needs to do some quality checks on this work and say, you know what, I don't know where you got your training from. I don't know what it is that you're doing, but this is not it, ma'am and sir.
What I think they need to do is just go back to on-the-job training, period, like they used to back in the day, because and then make it open to everybody.
Make it open to everybody.
Because that's really the best way to learn, because companies are going to streamline it so they give you what you need to know in the least amount of time. And then they're going to also, once they train you, they're going to give you support so you don't feel overwhelmed. I mean, because that's how I learned. That's how I got into coding. It was stressful, but it's doable.
A good company, because sometimes they throw you out there like, well, you get, I got mine, you better get yours. A good company who is invested in their employees' professional development. A good company will do that and make sure that they have the tools that they need to maintain as well as advance in what it is that they want to do. That's a great company. And I agree there should be, because every organization is different. So when you go into one organization, there are policies and procedures and rules and protocols and all of the things that they want to see happen or occur in the way in which they want to see it. So while you have that baseline knowledge of, well, this is how you get to whatever, that facility or that organization has some additional or different parameters and timeframes and productivity levels and skills and so on and so forth. So again, you come in with the initial knowledge of what you need to have, but then also know that wherever it is that you go, there are some additional parameters that you have to follow as well. So, and then gatekeeping 201 is always there. All right, my last story was about an imposter nurse, and I'll just say this real quick, that there was a lady who was treating people for 15 years and had a NARA license. Do you hear me? Not NARA license. She had now she was an LPN, and she worked inside of, she was an employee nurse. So inside of an employee, it was the Tyson food plant. So they had in-house medical clinic, and she worked there. Crazy part was that she was also married to one of the managers, the plant manager, but that's a whole other conversation. But yeah, she had worked there for years, seeing folks without a nursing license, and she had forged documentation regarding her LPN program. So she did go through school. So it wasn't like she just came in off the street and was like, you know what, let me patch you up. She did supposedly go through an actual program, but she failed the examinations and never took it again. And so she stole two people's identity and became a nurse, doing all of the things. All of the things, getting all of the money. Where was the gatekeepers there? But that's neither here nor there.
Thank you.
Who's watching them gates? Them is the gates that need to be watched.
Exactly.
Oh God. Okay.
But
go ahead.
I just can't believe that this whole thing has happened, because especially nursing has required fingerprints for years now. So that's why I'm not understanding how like that kind of thing is still allowed to go on. Now I get the whole nursing school thing, because that's something completely different. But these imposter nurses, like, how does that work? I don't get it.
Somebody knows somebody to know somebody. You know how that go.
Mm-hmm.
Like, oh girl, we got something for you. I got to come, just send me, slide me, do me. Yeah. Bless their whole heart.
Yep.
All right. Well, this was lively, very lively. Yeah. Lively discussion today. Thank you, Renee, for joining us and being part of our discussion. As always, the crafty coder came in and did her part. We appreciate you.
Yes,
helping us in the comments and giving us some food for thought as well. So we love the interaction and engagement, and so we thank you for being part of that. So again, thank you all for joining the Saturday morning tea. Let me just ask, was the tea spilled today? I have a whole bunch of notes over here, so I got some tea. Was the tea spilled today for you?
Absolutely.
If this information was valuable for you, help us share this message with others by liking the video, sharing this video, and subscribing to the channel. Y'all know I'm on a personal goal, 10,000 subscribers this year. Subscribe. Tell somebody. If you watch YouTube videos, go on over here to the professional reimbursement and just hit subscribe. They ain't got to never ever watch a video. Just subscribe. And also check out the Coding Nurse channel on YouTube. And they can subscribe over there to him as well. Right? Right.
That's right.
Last but not least, to my Clubhouse folks, make sure you click on the greenhouse to join the fun in our club, and you will be notified of our live broadcast, which occurs every Saturday morning, unless we tell you otherwise, at 9 a.m. Eastern Standard Time. Again, this has been a great session. Mr. Jesse, do you have any closing words?
As always, the tea was spilled. It was a very lively conversation, and the crafty coder wants to know where you can find the AMA articles.
Oh, I'll post them in the description. I'll go back in and update the information used in this video, and I'll post them there, so you can get that there. Or you can go to the AMA website. Well, you got to dig for that. I'll post the direct link to them in the. I'll make it easy. I'll post them in the description of our this video, so it'll be easy for you to find. All right. Cool. Again, this was a great session. Thank you all for joining, and remember, be safe, be kind, and don't wish for it. Work for it. Until next time.
Clarice.
Yes.
Once we disengage, don't disconnect. I want to talk to you offline.
Yes, sir. Uh-oh.
All right.
I'm in trouble, y'all. No, kidding. Until next time, take care.
Bye-bye.
Bye.